college, and
You muted. You
Yep,
muted me as well, Gary.
I muted everybody. I told you I was going to.
All right. Well, I'm pleased to announce our program today, and it's a big thank you to Debbie All, who brought Dr. Bills to my attention. And just so you know, if you don't know, Debbie is the executive director of the Mount Baker Foundation. And our speaker today will be addressing Rotary International's second area of focus, and that is fighting disease. So Dr. Bill Lombard is a retired Bellingham nephrologist serving on the board of Mount Baker Foundation. Dr. Lombard was one of the founders of the Mount Baker Nephrology Associates and longtime medical director of the Mount Baker Kidney Center, and an outpatient dialysis center that serves Whatcom County for nearly 40 years. The center is now operated by Deventa Health Partners. Dr. Bill has been in the community since 1981 and has dedicated his professional career to caring for patients with kidney disease. Through his work with Mount Baker Foundation, he continues to work on prevention of kidney disease, remaining active with improvements in kidney research and dialysis innovation, and facilitating the journey to transplant. Along with some of our other fellow Rotarians, Dr. Bill is also an avid pilot. Dr. Bill, welcome to the Rotary Club of Bellingham, and you have the floor.
Thank you, Paul, and thank you for all Rotarians for inviting us this afternoon, or actually, I think we invited ourselves as it turns out, but just a quick background is the Mount Baker Foundation is the legacy and legacy board from the residuals of the sale of the Mount Baker Kidney Center to the for-profit organization DaVita. We have maintained a focus on looking to improve the quality of life and the quality of care of those with chronic kidney disease. We've kind of always known, but it became more clear when we actually, as part of our work, delivered a questionnaire to our dialysis patients about what they considered important in terms of learning about kidney disease. Many of them felt they arrived for dialysis and had no idea why, and no idea what had placed them at risk for this problem. That and experiences myself and the other workers at the Kidney Center, particularly the social worker, have said, you know, this is something that really needs to be put out there. Well, March is National Kidney Month, and March 11th is World Kidney Day, and we're hoping to have out a sort of full community awareness of kidney health and, of course, chronic kidney disease and how we might prevent that. So we'll go on to our slide presentation here. Take me a second. Okay, is that showing up for everyone?
Yes.
Okay, so chronic kidney disease has been called the silent epidemic, and it's called silent for a couple of reasons. The first off is that it's fairly widespread and very few people know about it. And secondly, it's silent because the people that have the disease oftentimes are unaware until it's advanced and much more difficult to treat. And it's epidemic by virtue of its proportions. Virtually 1 in 3 of us is at risk for kidney disease. So if you look at the gallery on your Rotary Club and you look at the person to your right, the person to your left, and yourself, 1 of the 3 of you are at some risk for kidney disease. And it's the question you have to ask is, are you the one? So how big of an epidemic is this? Well, 15% of the US adult population, or 37 million people, are estimated to have chronic kidney disease. The unfortunate part of it is only 1 in 10 know that they have it. 1 in 2 people with very low kidney function, meaning those that are poised to start dialysis, do not even know that they have kidney disease. Our experience in Bellingham has been on the low years that 40% of people arrive for dialysis without having had a prior visit to a nephrologist, which means they've never had the chance to become educated about their disease, look at the opportunities for transplantation prior to dialysis, or even what the modalities of treatment are, or how they could have prevented their disease. A study that came out earlier this year, I guess it was actually the end of 2020, showed that in the Veterans Administration population, it's a large group of patients, 60% come to dialysis and have never seen a nephrologist. Furthermore, 1 in 3 adults that have diabetes and 1 in 5 with high blood pressure are highly likely to have chronic kidney disease. So this is a prevalent problem. Also, when you ask people about where kidneys are and what they do, they oftentimes kind of shrug their shoulders and go, well, I don't know. They get me up in the middle of the night. That's all I can tell you about them. And sometimes when I'm traveling, I got to pee when I don't want to. But sure enough, kidneys are 2 organs that exist or in our bodies outside the abdomen, but against the back muscles and just inside the lowest level of the ribs. Most people have 2 kidneys said to be the size of a fist. And this kidney on this picture on the right is a donated kidney being taken from a live donor to be placed into a recipient. And we indeed can get by with only 1 kidney. About 1 in 1,000 births are someone born with only 1 kidney, and they live a perfectly normal life in terms of quality and longevity. It also means that, you know what, we can all donate kidneys when our kidney function is still good and not have any problems at all. Excuse me a minute here. Okay, what do kidneys do? Well, one of the key roles is they regulate blood pressure, and they do this by both secreting hormones that raise blood pressure and also some that lower blood pressure, though those are less important. They importantly regulate salt excretion and fluid retention or excretion. They activate vitamin D, which is critical for absorbing calcium from our intestinal tract and for the production of parathyroid hormone, which contributes to bone health. They secrete a hormone which is directly responsible for red cell production. They filter 120 to 150 quarts of liquid from our blood daily. And the way they function is they absorb back the water that we need. They absorb back the nutrients like amino acids, glucose, potassium, sodium, bicarbonate that we need, and then leave the waste products to be excreted. The fluid is then finally balanced by other hormones which regulate exactly how much water we end up excreting. So they really have a wide range of important functions that ultimately maintain the internal environment of the body. So what are the risk factors for chronic kidney disease? Well, as we mentioned, diabetes and hypertension, or maybe I didn't mention that, but diabetes and hypertension are the most common causes. And in fact, diabetes accounts of itself for about 50% of the people that start dialysis each year. When you combine it with hypertension, it becomes closer to 75%. A family history is a significant risk factor because usually that means there's some predilection to either diabetes, hypertension, or to some of the more uncommon genetic diseases. Ethnicity plays an important role. Blacks, Hispanics, and Native Americans all have an increased risk for both chronic kidney disease and kidney failure. Age 60 and above is associated with a higher prevalence of kidney disease. And part of that is because in the age groups above 60, we oftentimes see more hypertension, more diabetes, and more vascular disease, all of which also contribute to it. And patients with heart disease, particularly heart failure, have a very high incidence of chronic kidney disease and something called the cardiorenal syndrome. And usually patients with heart disease, and particularly coronary disease, have coexistent vascular disease, which also usually contributes to chronic kidney disease. This just looks at the percentages of US adults, looking at age, gender, and ethnicity again. And we can see in age that the prevalence amongst 65-year-olds may be as high as 30%. Men have a higher incidence than women. And you can see that non-Hispanic Blacks are, in terms of the incidence of chronic kidney disease, is only slightly higher than whites, for example. But when it comes to the number that actually have kidney failure and on dialysis, Blacks are 3 times as likely as whites to have their disease progress to that point. And I think that that represents an underlying embedded problem with medical care for Blacks as a whole, and or how they're treated, which may be part of the systemic racism that we have seen. So how do you find out if you're the one? Well, one of the quick and easy ways is there's something called the Minutes for Your Kidneys. I'm going to pull that up. And this is from the NKF, National Kidney Foundation. If you go to this website, there's a very quick and easy quiz. It asks you if you have diabetes and if you have hypertension and family history. And when you get to the end of it, it'll say whether or not your risk is significant or not. And then it gives you the opportunity to actually go and request to obtain, and if you can, hope you can see this, I filled out the kidney quiz to make it appear as if I'm at high risk, and they send you a test to check urine protein that you can do at home. Most people with significant chronic kidney disease will have some protein in their urine, and this is a very sensitive test, which can help with that. So if you think you're at risk, this is a great way to start to find out if there's some issues you need to address. Whoops. Obviously, if you have a risk factor that we've discussed, then go ahead. You should certainly discuss this with your physician. Have a urine test done to look for protein, blood test to look for an elevation of the markers of kidney failure. And if you want to find out more about this, if you go to the mountbakerfoundation.org website, there will be information there to also help you investigate this further. So what do you do if your kidneys are losing function? Well, the most important thing is that you should discuss it with your physician and be followed by them regularly, depending upon where you are in the course of chronic kidney disease. It may be that you need to see them just once a year. It can be as often as every 6 months. And in patients that have more advanced disease, we typically will see them every 2 to 4 weeks when they're reaching a point where dialysis may soon be required. You should get a glomerular filtration rate test. This is actually from a standard chemistry screen. By measuring the serum creatinine in the blood, you can actually calculate the estimated glomerular filtration rate. Kidney disease is identified when you have more than 3 consistent months of a GFR less than 60. Frankly, if I were found to have even a small amount of chronic kidney disease, I would want to see a nephrologist to co-manage my care, and also to have them look further to make sure that this is not just the start of an uptick that's going to rapidly progress to loss of kidney function, and which sometimes requires a nephrologist to identify that. And when you do have chronic kidney disease, and I made this plea to all of my patients, if you change any of your medications, please call me and let me know to make sure that you're not taking something that's not going to be excreted from your body because of your kidney disease, or which is going to damage your kidneys further. Very important. Medications play a very significant role in both kidney disease and ending up with toxicity from medications which build up because of the kidney failure. When kidneys fail, there are really 3 options. The best is kidney transplant. And as I mentioned earlier, having a kidney transplant performed before you go on dialysis is the ideal way to do it, because the kidney transplant actually functions better, and you avoid all the complications of dialysis. If you do require dialysis, dialysis can be done at home, either by home hemodialysis, which is where blood is obtained typically from the arm and circulates through a machine and cleaned and then returned, or peritoneal dialysis, where a catheter is placed into the abdominal cavity and that fluid is exchanged 4 times a day to provide adequate dialysis. And you can also dialyze by hemo in the kidney center. And finally, palliative care is, over the last 5 years, has been looked at more closely, and really not everyone can or should have dialysis or transplant. These studies have mostly shown that the frail elderly actually live longer, have a higher quality of life, and stay out of the hospital if they choose palliative care over dialysis, when because of their frailty or advanced diseases, they really shouldn't. So let's talk a little bit about end-stage renal disease. How big of a deal is this? Well, as of 2019, which is the last data I was able to obtain information for, 125,000 people started at dialysis that year. There are more than 750,000 on dialysis who are living with a transplant now. Every day, more than 340 people start dialysis for the first time, and 240 people on dialysis die. For every 2 women that develop end-stage renal disease, 3 men develop end-stage renal disease. As you recall earlier, women had a higher incidence of chronic kidney disease, but they tend to not progress, probably because a lot of the chronic kidney disease is related to chronic or recurrent infections, which usually do not progress to end-stage disease. But to be honest with you, women do a better job taking care of themselves than the guys do. As we mentioned earlier, African Americans are 3 times more likely than whites to develop end-stage renal disease. Hispanics are 1.5 times more likely than whites. And as we mentioned earlier, in terms of how common it is, in the United States, for those adults 18 years of age and older, diabetes and hypertension account for 75% of the people that are on dialysis with end-stage renal disease. Let's talk a minute about the socioeconomic impact of chronic kidney disease and end-stage renal disease. This has tremendous impact on individuals' lives. And one of the things I used to tell patients was, this is a life-changing experience, and these people would have not known they had problems until I saw them, and might say that, you're at the point where you're going to need dialysis within the next 6 months and your life is going to change. Employment rates, for example, are 23% of those at the initiation of dialysis, whereas 6 months earlier, they were up at 38%. And for the same age group, this age group is 18 to 55, 81 to 83% of them were employed. Medicare eligibility begins after 4 months, at the start of the 4th month on dialysis. Prior to that, if you do not have insurance, you're responsible for that yourself. And if you have private insurance, it will cover it up to that point. And then the private insurance becomes a secondary coverage. Medicare charges are $248 per dialysis treatment. Private insurance and individuals with private pay are $1,041 per treatment, and there are 13 treatments per month. So if you do the math and you arrive for dialysis without insurance, it's roughly a $10,000 bill that will be charged before you finally get Medicare at the start of the 4th month. Medicare patients cost approximately $90,000 a year when they're on dialysis. If you do the math quickly, you'll find out that dialysis only accounts for a little more than a third of that. And that's because dialysis patients as a group tend to be hospitalized about 3 times a year and require more surgical procedures to maintain access to their bloodstream to allow dialysis to continue, and also experience significant cardiovascular complications. Patients on dialysis make up 1% of the Medicare population, but they account for 7.5% of the Medicare costs per year. In 2017, Medicare beneficiaries with chronic kidney disease, this is not on dialysis, cost $84 billion. And those being treated with dialysis costs an additional $36 billion. This is what I call the dirty little secret about chronic kidney disease, and that is that chronic kidney disease plays a role as a disease multiplier for cardiovascular disease in patients, and particularly patients with diabetes and hypertension. And consequently, they have this lot of downstream complications that are cardiovascular in nature and also counts for early deaths. For example, kidney disease is the 9th leading cause of death in the United States, but when you take into account that the majority of deaths in dialysis patients take place because of cardiovascular events, that really is sort of a disproportionate representation. So if you have chronic kidney disease, how can you lower your risk of progressing to kidney failure? First and most important is to learn from your nephrologist what specific treatments are for your particular disease, as well as what you can do to slow the course of your, or slow the progress of your kidney disease. If you have diabetes, managing blood sugars is absolutely critical, targeting an A1C hemoglobin less than 6.5. And if you have blood pressure, being sure that blood pressure as best possible is kept under 140/80. In terms of managing chronic kidney disease, having a healthy diet with low salt intake and low fat, and having a decent amount of exercise. Ideal body weights are associated with slower progression of kidney disease. If you do have chronic kidney disease, very likely you'll be prescribed medications which will slow the decline of your kidney function. Smoking is very detrimental to the progression of kidney disease, and mostly because of its effects to accelerate vascular disease. And then you should avoid exposure to things that can harm your kidneys. There are certain medications, particularly the anti-inflammatory drugs like ibuprofen and Aleve, certain antibiotics, particularly the sulfa drugs, and then the acid suppressing drugs like omeprazole, Proloxec, have been associated with a high frequency of allergic reactions that damage kidneys. If you take supplements, those should be run by your nephrologist and physician prior to starting them or continuing them. The dye that's administered for contrast or intravenous contrast for CAT scans and heart catheterizations can be damaging to kidneys, and you must always, or you certainly would always want to allow, if you're scheduled for any test, let them know that you do have kidney disease. And then kidney infections should be, you should be on high alert for those because they can increase the rate of loss of kidney function. Just a word about the Mount Baker Foundation. As I mentioned, the Mount Baker Foundation was started now about just shy of 5 years, and it was a legacy board of the Mount Baker Kidney Center and funded by the residual from the community benefit from purchase by a for-profit. The vision we had after 18 months of reflection was that individuals, families, neighborhoods, and communities would become stronger, healthier, and more resilient, and more compassionate generation after generation. Our mission is to identify, fund catalytic transformative initiatives that result in sustainable change. Our focus areas, in addition to quality of life and quality of care for the kidney disease patients, has been early childhood care, development, and education, and also addressing the upstream factors leading to chronic disease. And we do this to honor the hopes and contributions of Mount Baker Kidney Center founders, physicians, staff, patients, families, and the communities that made this mission possible. This is just a snapshot of some of the impact that we've had over the last few years. The foundation has provided dental care for the dialysis and pre-transplant patients who have not been able to access the kidney transplant list because of their inability to afford dental care. We provide money to fund the, or help fund the food bank for the Opportunity Council's East County Center. And we also granted a significant amount of money to the Kidney Disease Research Institute at the University of Washington for some microscopes for some key areas of research they're doing to reduce kidney disease. Well, thank you for your time. Please visit the mountbakerfoundation.org when you have a chance, and I'll be happy to take any questions.
Well, maybe before we take questions, does Mickey, Helena, or Joanne have anything to add?
I don't. I'm just glad that the Rotary Club welcomed Dr. Lombard. Thank you.
Okay, Anne, if you unmute yourself.
Yes, I don't know what hypertension is.
I do, I have it.
What
High
is-
blood pressure.
Oh, it's the same. Is it exactly the same as high blood pressure?
It is, yes, I'm sorry.
Why do people always use both terms?
Oh, well, not very clever.
I'm sorry, but I've been so confused.
No, and you're absolutely right, and it should, and you know what? I will change my slides to reflect that, okay? That's a great point.
Thank you. Because I don't have either. I'm so lucky. I've got a wonderful heart. You know, knock on wood. But I hear though both of those phrases and I think, well, maybe I have one of them. I know I don't have high blood pressure, but maybe I have the other one. So that's great. Thank you.
You bet.
Hey, Bill?
Yeah.
Congratulations on being retired, but historically, there's been a shortage or a difficulty of recruiting nephrologists to the community. What's the status now?
You know, Monty, it's actually, they're doing better now than they ever have. Right after you might say I failed retirement because I went back to work 2 additional times to fill in covering the hospital every 3rd week. And they now have 4 nephrologists and a full-time physician assistant. They're in good shape now.
Thank you.
But
Glad to hear that.
this portion needed, it's amazing. The number of dialysis patients currently in the county is about 185. When John Ransom and I started our practice back in 1981, we had 15.
Dr. Lombard, I've got a kind of an odd question. I have a female friend living in Toledo who has since died, but she had hypertension, diabetes, hypothyroidism, and in her late 60s, she developed kind of chronic end-stage renal disease. And rather than being placed on blood dialysis, she was placed on abdominal dialysis, and I've never understood why that was even considered. And it was so horrible that after about a month of that and a spontaneous fracture of a femur from the calcium loss, she stopped all treatment. But any thoughts on why someone might opt or be given only that as an option?
Sure, John. It turns out that, and I actually mentioned this briefly, that is actually one of the primary home modalities that people use. To be honest with you, considering her comorbid conditions, she sounds like she would have been a good candidate for palliative care. You know, she probably, to be honest with you, she would have lived longer and she would have been a better life. But peritoneal dialysis is probably one of the more rapidly growing modalities because, and if you don't have diabetes, because that method where they place a tube that goes inside the abdominal cavity, and then you have a 2-liter bag that you drain, an empty bag you drain into, and then you fill it up with another 2 liters 4 times a day, is a very gentle form of dialysis. So there are people who have problems with blood pressure on hemodialysis, and that ends up being sort of a fallback position where you can still provide them adequate dialysis. It's very gentle. Some people love it and would never do anything else. Frankly, unless you're very adept at making good connections so you don't risk contaminating it and causing peritonitis, it may not be for everybody.
Thank you.
Bill, Ann would like you to define modality, please.
Oh, modalities?
I have a question. How common is it to have CKD without having diabetes? Is it diabetes is mainly the trigger?
Well, diabetes is certainly one of the big drivers, Mark, but there's still a bunch of folks out there that have CKD without it. Now, if you don't have any of those risk factors, you don't have hypertension, you don't have diabetes, you don't have a family history, you don't have heart disease, you don't smoke, you're not obese, and anything you have is over 65, it's still worth getting blood tests done once a year to find out. Because Mark, that's not, I can't see you well enough to tell what your age is, but that wasn't meant to indicate that you're in this.
I'm only 25, but sorry.
Again.
But if it's still worth checking in that case. And again, the simplest things to do are talk about it with your doctor and say, hey, would you mind just doing a blood test to see if I have protein in my urine, and check a blood test to see what my GFR is.
That would be a normal part of just doing a blood panel, wouldn't it? I mean,
It absolutely would be, Mark, yeah. Almost all standard blood tests include a serum creatinine and now an estimated glomerular filtration rate.
Okay. All right, thank you.
Hey, Bill, just good to see you as a former patient and working together at the Kidney Center. I'm guessing maybe more than one person would like a copy of your slides. If that could be provided, maybe Sandy can contact you and have that happen.
You betcha. I'll send them to Sandy, and then Sandy you can contact her and get them, okay?
Thanks, Bill.
You betcha.
Andy already has them.
I have the copies, so just anybody who wants them, email me and I'll forward them to you.
Thank you, Sandy.
Hey, Dr. Lombard, how careful do we have to be with ibuprofen?
Well, yeah, I have to tell you, and young kids take it like candy. As we get older, it has a significant adverse impact. And of course, the other problem with ibuprofen is as we get older, first off, it can cause high blood pressure. It can also cause gastric ulcerations and bleeding in about 15% of people. And that can at times be life-threatening. So minimizing it is important. On the other hand, believe me, I know from my own arthritic problems that I still have to use it periodically, and I try to stick to as low a dose as possible that gets by.
How about Celebrex?
Celebrex, despite the fact that it does not cause GI bleeding, Monty, it does still cause kidney problem. It still decreases kidney blood flow, and you can see acute kidney failure from that as well.
Thank you.
Bill, great to see you. In terms of the ibuprofen, if you know you have normal kidney function, is it reasonable to use it, for the usual aches and pains of us old timers who are trying to stay active with biking and so on?
Absolutely, Steve. Again, I think the key is to use it judiciously. Try not to use it continuously. To be honest with you, what I do is I just take 200 milligrams twice a day because I've got a lot of arthritic issues, and I take it for 4 days in a row, and then I'll take 2 days off. And if you take at least 1 or 2 days without any ibuprofen, you pretty much are going to wash out and do okay.
This is Nikki. I have a question. Is Tylenol, acetaminophen, is that just as worrisome as the ibuprofen?
Good question, Mickey, and it is not. No, there's no indication that acetaminophen in the usual doses, meaning under a lot, which is like 500 milligram tablets a day, causes any significant adverse impact. Above that, the biggest issue is kidney injury. It is not in the same class as kidney problems.
What about naproxen?
It is just like ibuprofen, Mark.
Well, we
Bill?
better turn it back to Gary. We're running out of time. Thank
I
you.
want to
Dr. Bill.
really quickly get to Garrett because he has to sign off. And he wanted to talk to us a little about the vaccines in Washington. So Garrett, are you still with us?
I'm still here. Thanks, President Gary. I just want to give a quick update on vaccinations. I receive from, you guys actually met Dr. Carla Pudi earlier in the year. And the update is that in the hospital right now, Gary, I'm not sure if this aligns with what number you got. About 18 patients right now with COVID, which is a significant decrease over the last couple weeks. And we have gotten out so far over 5,000 vaccines, which is tremendous. They're really upping at the vaccination clinic. They're really upping the speed that we're giving them. There was a little bit of a spin on your head and do a little dance with the proclamation from the governor that has caused a little bit of confusion on how to ramp up our vaccinations. I think was the big push to, in fact, get this out to patients both with Peace Health as well as non-Peace Health patients. I'm still working on confirmation on how that process works. I know that folks are being scheduled that are not necessarily impaneled with Peace Health. So I just want to make sure that I get the correct information out as far as who to reach out to, because I'm told that the number that I listed here is not going to get you an appointment if you don't have a Peace Health doctor.
Right.
For the most part, people
My
are sticking with their
understanding
PCPs.
As of Saturday, they're still only signing up primary care Peace Health Medical Group patients for vaccines. And so if you're not a Peace Health primary care patient, even if you see somebody for cardiology and your primary care doc is with AFM or FCN, you're not going to get on the waiting list yet.
I don't want to speak out of turn, but I'm hoping I might have other news. We'll see.
Good. I know they want
I'm available now. We're scheduled for this weekend.
Mm-hmm.
Okay, great. That, it's changing right now really rapidly.
Right.
Garrett, do you know if Peace Health primary care patients under the age 65 are also getting vaccinated?
No, they're not. They're not currently doing the under 65 unless they have the certificate from the Washington State Department of Health website. If there's some folks like under, if you're 50 and over and living with someone that fits certain criteria, there are certain qualifications, but you do need to go get that certificate, is what they're asking folks. Otherwise, I'm not aware of exceptions being made.
Yeah, with regards to supply, is there any more information about how it is, how it's coming along and what it looks like? Is it going to be iffy for the next few weeks? Do you know any more?
It's touch and go right now. Thank you, Chuck, for your question. There was a lot of confusion. Like I said last week, we were standing up this new clinic, transitioning it out of the Cordata office building to the health education center near the hospital that you experienced. I agree, it's a well-oiled machine, even at its inception. But the problem became ramping up volumes to 600 per day, and now there's talks of getting up to 1,000 per day. And the problem has been whether or not we will be getting more vaccine, and that was uncertain last week. So it's really touch and go day by day. It's developing as we get more information. I don't have a firm answer.
And along those lines, I've heard that they're saying it may be okay if you get later than the scheduled 3 or 4 weeks. What do you know about that?
Just what I heard on NPR. This is something that we're learning as we go. And the latest that I heard this morning was, and it makes sense, if you get it beyond the recommended 2 to 3 weeks, it's just as effective. These are guidelines. We don't have data to show exactly what the correct timeline would be and what the marginal benefit at 3 weeks versus 6 weeks would be. All right. I'm going to bow out. Gary.
Any other questions I can probably help field?
Yep. I think so.
Maybe I sent this out in the chat and I'll just mention it is, I was just looking to see if I could come up with the phone number, but you are able to schedule appointments in Skagit, at Mount Vernon and their other location, as well as CMAR has some extra vaccines that if you want to stand in line, you can do that. So I'm just picking this up from my network here, and we're scheduled to go down to Mount Vernon in a week, I guess, to get the vaccines there. So just an FYI for those people that can't get them at Peace Health.
Catherine, is that at Hagen's or at a medical center?
It's at a medical center. It's the location is actually right across from the hospital in Mount Vernon, or the medical, whatever the medical center is called down there.
Okay.
So
I have that phone number for Skagit Regional Health if somebody wants it.
Go ahead.
360-814-6955. 6300 Skagit Regional, right across from the hospital.
Yeah, that sounds right.
And they're actually only waitlisting people right now. I got both my parents an hour before this meeting started.
Oh, darn. Darn.
Okay. Well, let me just interrupt for 1 second, and I want to thank our program. I want to thank Bill. Stick around for a few minutes if you want to continue asking questions of either Bill or myself on COVID, or to just talk with other members amongst ourselves. But I want to thank Sandy, Jan Marchbanks for being the greeters today, Mark Niddle for being the AV, Tom Grinstad for both Tatler reporter and editor. Our music was the Star Spangled Banner by the Rotary Brass. Thanks to Jennifer for doing our invocation, Paul Gray for bringing us the program, and John Harris for the book report. And with that, I'll let Sandy ring the bell and we officially bring the meeting to a close. Didn't hear it, but we'll say that it did anyway. And Bill's still on and is willing to take some additional